Okay, good afternoon and welcome everyone. My name is Fraser Keegan and I manage the innovation team here at the CIH, and I'll be hosting today's event. Before we start, I'd just like to acknowledge that the CIH is located on the traditional lands of the Kaurna people and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. Housekeeping items, please note that we will have the chat turned off, but you can start a conversation by using the Q&A tab at the top of the screen. The first section that we have will be the presentation, and that part will be recorded and it will be published. At the end of the presentation, we will stop the recording and then we can move into the Q&A. So please feel free to get involved with that. So for those of you who are unfamiliar with the Commission on Excellence and Innovation in Health, or the CIH for short, we're the lead agency for innovation in healthcare in South Australia, and our goal is to bring together consumers, clinicians and other collaborators in order to turn little ideas into better healthcare. So as we say, together, creating health and prosperity for all. And so to do this through the showcase, we support the sector to come together to imagine new ideas and to see what the implications might be on a larger scale. And in essence, that's what the showcase is about. What we're trying to do is to bring together all of the small ideas, and that in essence is what the position of the Commission is. It's all about sharing ideas, improvements and innovations and working together for that greater good. So this session, each session goes for about 40 minutes. It will be made available online. And what we're trying to do is just to provide that space to explore what others are doing and what they're learning. It's not meant to be an overly formal context. It is literally about us as an industry and a collective coming together to see how can we progress healthcare in South Australia. So if you do have a problem that you've been grappling with, if you've had any success or you've had some learnings along the way, or if you have some themes that you'd like us to explore through the showcase series, please reach out and let us know via the email address on the screen. We're always interested in having that interaction and that connection to the industry. So have a think about it. If there's anything you'd like us to focus on, by all means, reach out and let us know. So as most of you would be aware, because you've registered, that the theme for the 15th series is about digital and data-based innovations. And what we do know is that innovation and data are interdependent in so many ways, but we also know that the landscape is changing rapidly. So each of our speakers has been asked to describe the work they do in this space and how to demonstrate this interdependency and what actually is occurring along that innovation journey. Just a little shout out to provide some context. We have up on the screen now the innovation model that we published in 2024. And what that does is it provides a staged and stepwise approach to moving from an idea into something that can be scaled and deployed sustainably. So if you visit our website, you'll see that we've uploaded resources and guides and templates. So please feel free to have a look and pass it on to anyone else that you think might be interested. So just a reminder that after today's session, we do have one more speaker. So if you haven't registered for the final event, please do so now. The QR code is on the screen there, and we'll pop that up at the end of the session so that you can have access to that. And again, please share that across your networks. We're trying to make sure that everybody who wants to have some insight into what we're doing has that opportunity to do so. So it's now my pleasure to introduce and welcome today's speaker, Dr. Joshua Ross. Josh is the Executive Director for Data Analytics and Insights in the Department for Health and Wellbeing, and he's also a Principal Research Fellow at SAMRI. And today, Josh is going to help us understand his current role with a particular focus on data and AI governance, strategy and data-driven insights, and equally the journey that brought him to it. So thanks again, Josh, for speaking today, and over to you.
Right. Thanks, Fraser, and thanks CIH for the invitation, and thanks all attendees for coming to listen to my contribution to this series. So the title of my contribution is Enabling Innovation in Health Through Executive Leadership of Data. I should also say, looking back at that previous slide, that I do own more than one jacket, but just to make sure you know I'm the person who've worn the same one today. I too would like to acknowledge that I'm sitting on Kaurna country and pay respect to elders past, present and emerging. Okay, so what I wanted to start with was effectively the vision that I have for where I want to take data and analytics within SA Health, and that's to realising a learning health system. So data on its own is really important. We need the individual data points for when doing point of care, clinical care, about what the history of the patient is, and that's just raw data that's provided. And we also need data for statutory reporting to ensure that we receive funding and can operate health system. There's lots of use just for data on its own, but I think the real value and real opportunity comes from when we use that data to generate insights and then to perform or take action upon those insights. And then effectively, we need to rinse and repeat that. We need to monitor, evaluate the performance of the actions, through that gathering more data, which generates hopefully more insights and improved actions. And I guess it's this learning health system, which is where I see innovation within the health system emerging through. So this is kind of the vision that I have for where I'd like SA Health to go and what I thought would be a starting point for the talk. Now, if we think about the key enablers for this to happen, the main enabler is data. And that data needs to be fit for the purpose that we're using it for. So there's different levels there of quality that's required based upon the decision that's needing to be made or the action that we want to take. We also need to make sure that we're in alignment with legislation. So we need to make sure it's appropriate to use that data for that purpose, and that the use is also appropriate of being used. Finally, we need to consider the timely provision of this. So a large message that I've heard since being in this role for now a bit over a year is the delays and sometimes unclear pathways to go in terms of accessing data required to enable innovation and research. And so timely provision is really important. And this is often captured in what the purpose of data governance is. It's about the right data to the right people at the right time. So on the right, I've kind of basically put down the different topics or tools or parts that would enable that data being fit for purpose, appropriate to use, and timely provision. And so there's overall data governance, there's data quality, which includes data standards and interoperability. I believe the last talk in this series was on interoperability, and Mark, I'm sure, gave a fantastic presentation on that topic. There's also the ability to use technological solutions within this software to really enable and speed up that timely provision aspect of it. Wouldn't be complete a talk on data and analytics, in particular in health at this time point, if we didn't talk about AI governance. And then I also see a big role to play through data linkage, linking our assets together, not just looking at a data in isolation or even just hospital data, but actually broadening that out to broader health data and possibly even broader again. And also secure access environments as a way to look to facilitate the use of our data with researchers and those external to SA Health. And so throughout this talk, these will be kind of the themes that I'll address on following slides. So just a little bit of a background. So I was told as part of this was to provide a bit of the journey to where we are now and our approach to innovation. And so I come from a research academic background, and so with that lens, there's always an element of innovation in that space to try and be innovative in the research. My focus has been around data, so from maths and statistics background and trying to make data-driven decision making. And throughout the career, there's been a shift from a more methodological and theoretical focus to becoming more and more applied throughout that process and starting to interact more with SA Health and SA Health's data during that process. And I guess the pinnacle of that section of my career for me and a personal highlight was when I was able to be the lead COVID modeler for SA Health. And so along with collaborators at the University of Adelaide and SAMRI. We produced the research, which produced COVID-ready modelling plans for when we're at 80% vaccination coverage and then subsequently for 90% vaccination coverage. Those plans informed the settings that we had when borders were opened in SA. They were quickly made fairly irrelevant because we had the Omicron emergence, but we were able to also use data and modelling to identify the likely emergence and introduction of Omicron BA1 into our state, or at least a variant, not knowing it was Omicron, before we even knew that Omicron had reached Australia. The modelling that we did also informed the public health and social measures and the test, trace, isolation and quarantine settings that were in place. So we worked very closely with the Chief Public Health Officer during this period, and the decisions that she took and that the committee as a whole took were informed by this data and this modelling and analytics. It then pivoted as we went on to actually trying to focus on what is the demand on hospital and trying to do forecasting of hospital demand through time. Now, in this particular situation, there was an emergency declaration, and so data provision was made possible through that mechanism. It's not always as efficient. And I guess that's where my current position, an executive position that I now occupy, it's fundamentally about trying to maximise data and analytics use to drive evidence-based decisions in SA Health. So this paragraph at the top of this slide is actually a cut and paste from a paragraph from the job description. And it was really that opportunity to look to maximise data and analytics to drive evidence-based decisions, which really attracted me to apply for the job. I think within that, there's in the second part of that statement, there's a contemporary data governance framework as one of the goals, and then also about the actual analytics and innovation. So when I came in, I had a strong appreciation of the importance of data governance and was really interested in looking to develop that. But I think, like many others, when you hear data governance, it feels a bit, I don't know, it comes across as being slightly boring or slightly policy based. And I have to say that it was more the analytics and the data-driven decision making which really got me more excited at the start of this process. However, now having been in the role for over 12 months, and during that period, it's really become evident to me that data governance is really incredibly important and foundational. And I think it is actually the key to creating a data-driven and evidence-based decision and innovation environment in SA Health. I think of the multiple things that we could do in health, this is actually one of the things we could do which would have the largest impact on innovation in health, is having a really contemporary, modern and effective data governance framework. And that's what we're striving to achieve and starting to even prioritise even more to try and get this into place. So this is just a slide now that just expands a little bit on the work we're doing in the data governance space. So the idea is that we have enterprise-wide consistent data domains. In the top left of the slide there, we have the 9 endorsed data domains. So they're going to be consistent across all of the enterprise. So within SA Health, we obviously have LHNs and DHW. So each of those are going to have this data domain. And within that, we're going to have also consistent sets of subject areas and data items. And at the moment, we're looking at developing that for the workforce data domain. And we're about to start to look to roll out positions in the other data domains and start the same process. And then each of those kind of levels, data domain subject areas, actually aligns with a role within the data governance structure, which has a clear responsibility associated with it. So this brings clarity of who is responsible for what, and that also allows the ability to map that over into a technological solution, which I'll come to in a little bit. But it's about being consistent, being able to have clarity, identifiability, being well defined is the basis. So just a little bit more on the data governance, just a second slide on it of where we're going. Obviously, the data strategy needs to be aligned to data governance, and I'll talk a little bit more about the data strategy in a moment. But our data strategy, the first data strategy that I've been in charge of facilitating since being in the role, is going to focus on data at the core. And so this is trying to establish that data governance framework and operationalize it. And we have a roadmap and plans, and that's become a priority, as I said, to accelerate. Within that data governance, as you've seen in the previous slide, it's about organisation, roles, sources of official data, that clarity. Alongside that, we need to have data management capabilities, embedded data and data quality. And I think the really important part of this is the supporting instruments. So the policies and procedures gives the clarity of process, but the technological solutions allow us to have online catalogues of our data assets, to have those data assets and elements, data items within those data assets have documented definitions linked to it, which can be accessed electronically. And also we could look to have, with the roles associated to those data assets from the governance framework embedded in the technology, we'll be able to have requests, approvals, and even provision of the data, hopefully via DAP, all through a technological framework. So that's the kind of goal vision that we'd like to work to. Obviously, a number of steps to reach that goal. And I think each step, though, we take is in the right direction and will allow and unlock further innovation. We're also making sure that research is a focus within the data governance framework, and I'll talk a little bit in a little bit around secure access environments or trusted research environments, also about synthetic data capabilities that we now have within SA Health, and once again, the linkage of data. So on the data strategy side, so as I said, data governance, the foundations is the key aspect of this data strategy. The idea then, once this data strategy is realised, is to move to starting to look at data analytics, and then after data analytics to start to look at the learning health system. But within this first foundational piece around the data foundations, in addition to the data governance, linkage is another key component that we've got. So there's a huge benefit that can be realised by combining hospital data with wider health data, possibly with registry data. Obviously, there'd be benefits to even going to primary care and to aged care. Each step, any step of linking more data provides more information about the patient, which can improve insights and innovation. So SANT Data Link, which is come from a well-credentialed research field, providing linkage services across broad assets in SA and Northern Territory for data linkage, has come into SA Health, and we now have the potential to use that expertise and resources to provide this service and to realise these benefits. And so we're on a journey at the moment to establish that. We also, with that being in SA Health and with SA Health data, if we de-identify that data, noting that when we link data assets that individually might be de-identified, we increase the risk of identification. So extra care and caution needs to be taken with linked assets to be genuinely de-identified, which effectively means there's no reasonable prospect of re-identifying the individual. If we can do that, then within legislation, we can then provide these for SA Health innovation. To complement that, we're also looking at establishing what's called a trusted researcher or secure access environment. So this is an environment that is highly secure to put SA Health data in, which allows us to control, so external people, external to SA Health, are able to come and access that data in a very controlled fashion. So instead of sharing data and taking data away, they come in, the data's been provisioned, just the data that we've agreed for them to have, and they will be able to then analyse it and do research on it. And I think this is a really important way to start to build trust and to start to see that combining of research and external partners with SA Health to drive innovation. I think another important part of this, which we're embracing in our first data strategy, which starts to touch upon the digital side of things, is to really support interoperability. So the ability for systems to communicate with each other easily in terms of the data transmission standards, which also allow us to make sure that data is well defined and well understood within systems. And that also aligns with supporting a national agenda, which I'll expand upon a little bit as well. So just on the data linkage, just one slide on that a little bit more. So as I mentioned, SANT Data Link has a long history in linking a broad range of data together. So we should now be able to look to make use of this expertise and the data assets that they have and provision through de-identified linked assets for use. The other agenda of note here is the initiative of Digital Health Australia with Health Connect Australia. So this is an initiative to quickly and securely link and share data for patient information. And so the goal there is to have a complete health linked information for those that haven't opted out of a patient's history and all of their data. And so this is the national agenda supported by largely interoperability and data standards. That's part of our data strategy, sorry. And so you might say, well, if Health Connect is on the horizon and we're going to link all that, what's the role for SANT Data Link? But there's definitely a role, at least in the interim. This is still a long way off with Health Connect. But I think there will always be a role in terms of bespoke projects and bespoke data. And there's also legislation that still needs to be worked through here with the use of that data and national data, possibly across different states. Whereas if we're looking at it, keeping data within SA Health and providing linkage within that, we might have more flexibility and be able to maximise benefits, subject to still keeping data safe, secure, and meeting all legislative requirements. So I mentioned a couple of times now secure access environments or trusted research environments, and that's sometimes also called safe havens. And these I think, really are highly secure environments to allow for controlled access to SA data. And I think it's about facilitating trust and starting to make it a clearer, once again, more efficient pathway in which we can provide access to our data to trusted partners. And I think ultimately we need to move towards trusted researchers rather than trusted research environments. And so we are looking at supporting national agendas in which we'll have nationally consistent agreements so that researchers only have to do essentially one set of training or courses to be accredited to access secure access environments. And they might have a trusted researcher passport, which means they are then able to access secure access environments across Australia. Thanks to a recent workshop facilitated by Health Translation SA based at SAMRI, there was a workshop which actually showcased a number of these different environments that we have within Australia, as well as an international perspective on these. And there are different technical designs that can be used here with different trade-offs for use cases. So this is like on-prem versus cloud. Obviously, there's issues around scalability of having a cloud-based solution versus an on-prem solution. Also benefits maybe as software as a service in terms of pay for what you use. But it was also pointed out that in that environment with more variable costs rather than fixed costs, there is the possibility for bill shock, which happened with some of these large AI projects. So we need to understand what are the use cases. We need to be forward thinking in terms of AI and similar technology. And so we're currently scoping those use cases and the technical design pros and cons, including the possibility of a hybrid approach, which tries to get the best of both worlds. So interoperability, I probably don't need to say much about. This would have been addressed in the last seminar within this series. But basically, we've adopted interoperability as one of our 7 principles within SA Health, which is that the end-to-end data capture should be enabled through the application of interoperability standards and technology as a default. Sparked is a consortium in Australia led by CSIRO, which is looking to support this interoperability agenda through FHIR, and SA Health, as you can see there on the bottom right, is a founding member of this initiative, and so we really are supporting this agenda. We are also adopting common data models across enterprise-wide. So if you think about different sources here, could be different LHNs collecting different data, and they might do it in different ways. If we can actually have that all transformed and under a common data model, then it means that we know exactly the format and the definition of the data that we're using. And so analysis methods can be applied identically, or the data can be combined together with that confidence that it is the same thing that we're combining together. And so we're looking to use an OMOP, common data model, as the foundation for our LHN and hospital data, the clinical side of the data. And we're looking at establishing enterprise-wide consistent models where common models external don't exist. So workforce is an example of that. And I guess the theoretical possibility of this, which is really interesting, is that if we have the data is completely interoperable and in the same standards, then we can actually move towards, rather than a trusted research environment, a secure access environment where the researcher has to actually still come and see our data and use our data, to that algorithm to analyze the data can be developed anywhere, because you know exactly what the format of the data will, what the standard is, what it means. And so then you can essentially just send the algorithm to be executed within our environment on our data. And then the release of that data, we only have to think about the data that the final outcome output of the analysis is the data that needs to be considered to be transferred and to meet legislative requirements. And this should open up a lot more flexibility and innovation as well. The other thing it was enabled, a lot of time is spent on reporting for statutory requirements. We need to say that we treated this many patients with this condition over this period of time. And a lot of that, there's a lot of nuance to that and technical specifications required. But if everything, once again, is standard and is in exactly the same format, we could almost get to automated reporting, where we run an algorithm that is the same across all of Australia, so federated, which extracts, and we know the quality and standard of that data. What it also facilitates is getting towards high frequency health record matching, which enables person-centered care as well as more timely system-wide insights. Okay, so as I said, a talk in health around data analytics wouldn't be complete without mentioning AI. AI has lots of hype and commentary around it, not only in benefit, but in potential risks. We really want to allow innovation in SA Health, including of AI, but AI does require some extra considerations, and we've worked through those, and they're into a framework and an accompanying policy, which will soon be proposed to the Health Chief Executives Council within SA Health, and then subsequent to that will go out to broader consultation. Obviously, the extra risks that come, or at least are amplified through AI, is the data security aspects, with the number of calls that are made to different algorithms within it, and that a lot of those are, rather than a methodology which is part of a toolkit which is definitely confined to your environment, they're often making calls typically that are outside cloud, outside SA Health infrastructure. So there's some data security provisions we need in place. The other one is with the data and the high dependency on data for training within these algorithms. Depending on the type of algorithm, you could have drift, or for large language models, hallucinations. I guess with large language models, you also have that they are designed to be confident in what they present and to make it look real. And so those hallucinations can also be difficult to detect. So I think we also need some guardrails around that, which we've worked through and we'll be proposing soon. And that we also think there needs the requirement for these to be trained in the way they're intended to be used in the trial of them. So hopefully that will be coming out soon. As we said, we want to allow innovation, but there are some guardrails that just needed to be put in. I think one extra comment on this aspect of it, though, is that I think once you have the data governance sorted and we know the data and who's responsible and all of that, and the legislative landscape is understood of what we can do with that data, I think once we've got that established, when new technology comes in, such as AI, and AI won't be the last, I don't think there is a need I think it will make it a lot easier moving forward. You then just have to identify, well, what are the novel risks or novel aspects of this? And it's about just establishing then and the guardrails for those particular aspects. And when a new innovation like AI or something comes into play, where it's going to be there for the long term, we don't want to have to put in place a whole new set of measures that are committees and extra work. We need to have it that there is a period of upskilling, and then it needs to be a model that becomes integrated as business as usual as soon as possible. And I think moving forward with where we're heading with our agenda, I think we'll be able to be ready for the next AI and be more timely in allowing that and supporting it with the appropriate guardrails than what we have been with AI. So just to return to the vision, the goal slide for me, trying to embrace the learning health system, I thought I'd just put in the talk at the end, there are some green shoots that we're actually starting to see this being realised within SA Health already. There's some glimmers of this emerging. So one project I've been involved in is in the GEM rehab maintenance care cohort in SA hospitals. There's a collaboration had been formed between data and analytics experts, clinicians, as well as health executive support. A nice outcome of this project is that we now have a linked patient journey data asset. So we now have the ability to, given via DAP for anyone to be able to get a ID which links all of the history of a patient's journey from when they enter a hospital until when they exit a hospital that's possibly a different hospital in possibly a different LHN, but a part of the same course of treatment or the same patient journey. We were able to, based upon that, or CEIH actually led the analysis of this as well in collaboration across all of DHW, an analysis on that. The analysis of that generated some insights, which we then had a workshop. I think the workshop had 60 to 80 people, broad representation across clinicians, finance, executives, data and analytics. And out of that workshop, there were clearly support for some of those insights, some discussion around what the actual causes were, underlying explanations for it. And out of that, some actions have been identified that LHNs will be implemented. And we're now, my team is now looking at off that patient journey, calculating an agreed set of metrics, which we believe should be monitored and evaluated to see if those actions that have been identified will improve the metrics as we hope within this space. So I think this is kind of an example of where we're heading, or where I'd like SA Health to head with this learning health system. So this is one of a number of projects that deep dive projects, or an analytic process that projects that my team are leading. So that's the GEM rehab maintenance deep dive. There's also one focused on ED acute care, obviously aged care, and the aged care decrease in availability has resulted in an increase in our patients waiting for aged care within hospital and maintenance care. So we've done a deep dive into that, looking at the impacts of that explicitly and trying to quantify that and where there might be insights for improvements. And also we're doing a piece of work in collaboration with SHCC, the State Health Coordination Centre, looking at out of hospital and hospital avoidance measures. The goal of all of these is about trying to sustainably reduce transfer of care time. Transfer of care time is the time from when a patient in an ambulance reaches the hospital until when the ambulance officers declare handover has occurred. It's said that 30 minutes is defined as a reasonable time for that to occur, and any TOC, transfer of care time, over 30 minutes is what ramping is calculated upon, and whenever that's over 30 minutes, it contributes to what the ramping is. And so we've seen that increase in ramping and obviously an increase in TOC over time. We're also involved in a national primary acute care data linkage project where we're looking to start to look to link primary data with hospital data and the benefits that could come from that, and also focused on the ambulance ED interface. So I think that's it from me. Just in summary on the final slide, as I said, the title was about enabling innovation in health through executive leadership of data, and I hope I've demonstrated that in the bit over a year that I've been in the position, in a position that is about executive leadership of data. I hope I look to see that the initiatives I'm taking and what I'm trying to support is about enabling innovation. The Data Governance Foundation, as I said, I've come to realise that I think this is really, really one of the biggest impacts we can have in health is sorting this out and realising the goal of what's potential in that space. And the data strategy for SA Health and strategy for the data strategy, I guess. The first data strategy, I said, we're focusing on data governance, linkage, secure access environments, and supporting interoperability standards for a national agenda. Once we hopefully start to move to having that data governance realised and in place, we'll start to look to increase in data analytics and literacy across SA Health. And then the revised data strategy, now looking much further ahead, will hopefully be about how we can embed learning health system across the data analytics space within SA Health. And so thanks for listening, and I'll stop there.